because our next speaker, Andy Voigt, who heads up the EP services here at Shadyside, as many of you know, is going to be talking about surgical approaches for AF. And we'll start off with a question right up front, Andy, that you could perhaps cover. And when should we consider AF convergent therapy for our patients? I'm sure you'll address that.
Perfect. Yeah. Thank you, Mark, for inviting me to speak. And thank you, Dr. Saba, Dr. Jan. It's a real pleasure to be able to have an opportunity to talk about this very challenging issue that we face, trying to help patients with persistent AF as opposed to paroxysmal. We're much more successful at that. So I'll talk about this unmet need that we face as cardiologists and EPs in terms of patients who have been in atrial fibrillation persistently for a prolonged period of time. I'll talk about the status quo, which is that we're very good at PVI, pulmonary vein isolation, as Dr. Jan mentioned. But is there anything more we can offer these patients, because they still suffer in spite of that approach? We'll talk about convergent ablation, which is sometimes known as hybrid ablation. And I noticed you guys called this a hybrid educational event. So we'll talk some more about that. But convergent ablation, this is where we collaborate with surgeons to try to treat patients with persistent AF. And then we'll talk a little bit about our early experience at UPMC Presbyterian Shadyside with collaborative ablation. So I think I'll just very briefly mention, this is very similar to Sandeep's patient that he just mentioned, but we have a 58-year-old female with persistent, very symptomatic AF. Patient's been in the rhythm for over 6 months. Intrusive symptoms, early recurrence post-cardioversion, and in spite of dofetilide, the patient is obese, is compliant with CPAP for sleep apnea, has been unsuccessful in attempts to lose weight, is anticoagulated with risk factors for stroke, and again, the level of rate control is sort of meh. The rate's 95 average, and basically the patient also is developing some heart failure with reduced ejection fraction. So how can we help that patient? Should we offer intensified medical rate control? Should we, as Dr. Kancharla suggested, should we consider AV node ablation by the pacemaker? Should we just go with amiodarone, although she's relatively young? Should we consider catheter ablation, PVI? We're very good at that. It's very safe. Or should we consider surgical approaches? So, I think one of the things I want to argue in this brief talk is I want to argue that there is a role for surgical approach to atrial fibrillation in 2022, even though we've become very facile with catheter ablation. So we all know that persistent atrial fibrillation doesn't occur in a vacuum. There are a lot of risk factors associated with persistent and longstanding persistent atrial fibrillation, which we really need to address. And I know a couple of the speakers have already mentioned that, but it's very important. And some of these risk factors are reversible and some of them are not, but the ones that are reversible, we need to really, work on. And even if we can't win the atrial fibrillation battle, we can get our patients feeling better and improve their quality of life, probably just through lifestyle interventions alone. So when I take a step back and look at the struggle of management of persistent and longstanding persistent atrial fibrillation during my career, we've had lots of sort of peaks and valleys. At one time, there have been lots of contenders that really seem to be very promising, and we're going to ablate outside the pulmonary veins, outside the antral tissue around the pulmonary veins, and we're going to get better outcomes. But really, one after another, these have actually fallen into disfavor. For example, CAFEs and empiric lines, the STAR-AF2 trial pretty much showed that doesn't add anything to PVI. I was personally involved with studies with ablation of rotational activity in the atria, rotor mapping and ablation that was shown to be ineffective. There are lots of contenders that seem still fairly promising, but we are waiting to see how the data is going to play out. And one of those is posterior wall ablation, which we'll talk about pretty extensively. So we know that persistent atrial fibrillation results in atrial substrate abnormalities, progressive enlargement and fibrosis. The mechanism actually of persistent AF isn't even well understood. We know that there are different competing hypotheses in terms of mechanism. And we haven't totally worked that out. But one of the leading questions is whether we could be dealing with some endocardial and epicardial reentry. And maybe by ablating on just one side of the muscle, we're not truly addressing the substrate. We know that that atrial fibrillation is progressive, and we know that lifestyle factors play a big role in this. So this is actually data that Dr. Jan and our group published about 5 years ago, showing that if you take a pretty straightforward approach to persistent atrial fibrillation and you just do cryoballoon PVI, that you have about a 40 to 50% recurrence in a year. And I think we should mention that this is not a long-standing persistent population. This is mostly an early persistent to persistent population. So these aren't generally patients who've been in AF for a year or two, as we mentioned before. But even with that early persistent and persistent population, there's a lot to be desired here in terms of outcomes. So the STAR-AF trial that I mentioned earlier was a very practice-changing trial in atrial fibrillation management, in which patients were randomized to just PVI or PVI plus additional ablation. And in this case, I think it was mostly cafe ablation and lines, like a roof line, left atrial roof line. And essentially, there was no difference in outcomes with the additional ablation. So those additional ablation, those lesion sets have really fallen out of favor. One common approach that we're currently using in EP practice is to isolate the pulmonary veins, but then to also do additional lines to isolate the entire posterior wall of the left atrium. And that does make some sense. You'll often hear that the posterior wall and the pulmonary vein share the same embryological origins, and that the entire posterior wall can be a source of triggers for atrial fibrillation and perpetuation. So essentially, it's a very common approach to do that and it's actually technically feasible. The problem is that is reconnection. It's kind of the bane of our existence in EP in terms of our current technology when we ablate atrial fibrillation. This is a patient who had an initial procedure, which was pulmonary vein isolation, and then a roof line and a more inferior posterior line to isolate the entire posterior wall. Well, the patient came back with atrial fibrillation, and the initial map here in sinus rhythm actually shows a clear leak through the roof line. And this is a very common problem with catheter ablation. And this is actually just a case report I found that is showing a very interesting phenomenon in which a patient who has had multiple catheter ablations prior for persistent atrial fibrillation continues to have AF. These authors took the patient back to the lab and essentially showed in this map in the upper right that orange is essentially low or no voltage. So endocardially, there was no really evidence for electrical activity in the posterior wall. However, they did simultaneous epicardial mapping and showed lots of electrical activity in the epicardium. So it is possible to dissociate the endo from the epi, and it's possible that some of the perpetuating impulses that are leading to atrial fibrillation persistence may in fact involve the epicardium. So one of these other promising areas is, well, for persistent atrial fibrillation patients, should we isolate the entire left atrial appendage? We isolate the veins and then also isolate the appendage, which is technically feasible. And actually, this belief trial showed that there were better outcomes and more sinus rhythm in patients in whom you isolate the left atrial appendage. However, that comes with a major headache, which is that there's an increased stroke risk in these patients in whom you have completely isolated the left atrial appendage. So at that point, you have electromechanical dissociation of the left atrial appendage, even in sinus rhythm, and they may be at increased risk for stroke. So unfortunately, this is a population in which if you undertake this left atrial appendage isolation, you need to consider closure of the left atrial appendage or lifelong anticoagulation. So that's not really a trade-off that most of our patients, at least our healthier patients with paroxysmal atrial fibrillation, are willing to make. So the gold standard surgical approach, as we all know, has been the Cox-Maze procedure. And the original was the Cox-Maze 3. which actually involved sternotomy and a cut and sew maze. So cutting lines in the atrium, the right and left atrium, isolating the pulmonary veins and re-sewing. This was actually a report from the surgical literature from a few years ago in which they reported on 59 patients who actually had sternotomy. They were a persistent and longstanding persistent population. 80% had previous catheter ablations. This is a very difficult to treat population for sure. These patients almost all underwent excision of the left atrial appendage. So this is about as invasive as it gets. And they did show in 7 years follow-up that 70% of the patients were in atrial fibrillation off antiarrhythmic drugs and off anticoagulation. And only one patient required a pacemaker. So I guess we should ask ourselves, well, why aren't we using that gold standard surgical approach? Well, I think that there's morbidity and risk associated with sternotomy, clearly, and poor patient acceptance. There are questions about atrial transport function after you do such an extensive lesion set. There's a risk of needing a pacemaker, although it was low in this study. And I think it would, it's questionable whether you can reproduce these kind of results. So what would an ideal procedure look like for persistent atrial fibrillation? Well, we want durable lesions. We want to minimize incomplete lines, which can be proarrhythmic and lead to atrial tachyarrhythmias. We clearly want to mitigate the stroke risk. We'd like to exclude the left atrial appendage and electrically isolate the left atrial appendage. The Watchman, recall, can exclude the left atrial appendage, but doesn't electrically isolate it. We want to avoid implanting a foreign body in the endocardium if we can to mitigate the risk of device-related thrombus that we heard about earlier. And we'd like to reduce the risk of a very sort of sinister and catastrophic complication that occurs late after catheter ablation, very rarely, atrioesophageal fistula. And of course, we want this procedure, whatever it is, to work better than PVI alone. So this is what led up to convergent ablation for atrial fibrillation, which again is a combined epicardial and endocardial approach. So what we've been doing at UPMC is I've been collaborating with Dr. Ibrahim Sultan, one of our cardiothoracic surgeons here. He's been doing an epicardial approach, subxiphoid approach with epicardial posterior left atrial ablation with overlapping lesions in the left atrium. And then also putting, via mini thoracotomy, putting a clip in the left atrial appendage. Patients usually stay in the hospital for about will stay in the hospital for about 2 nights typically. And then 1 to 2 months later, the patient returns for endocardial ablation. Endocardial ablation typically involves some touch-up of the posterior wall and also PVI if necessary. So again, we've been doing a staged approach, which I think is the way this field is moving. I think initially the thought was we're going to do this all at once for the patient. But I think it's an awful lot for a patient to go through in one day. And also there are lots of logistical issues with trying to schedule a CT surgeon schedule and a physiologist schedule, and then of course the venue and things like that. So this has been working out pretty well. So if you look at a voltage map, for those of you who are not electrophysiologists, a voltage map is basically color coding the amplitude of voltage in the left atrium. So if you look at the left panel here, you see that after the initial procedure, which was surgery, which is the epicardial ablation, you see that part of the posterior wall was turned red, which means low voltage, whereas the right panel shows you after the endocardial ablation with touch-up ablation of the posterior wall and encircling lesions around the pulmonary veins, you have electrical quiescence of the entire posterior wall and the pulmonary veins. And this is a similar example showing you, again, panel A, after the surgeon does the epicardial procedure, and then panel B being after the catheter ablation approach. So there is some data suggesting that this clip that's applied externally and epicardially actually electrically isolates the left atrial appendage. This is essentially showing that there's both entrance and exit conduction block into the left atrial appendage tissue after the clip is applied. So what are the advantages of convergent ablation? Well, essentially, we might be able to decrease the risk of atrioesophageal fistula because we're actually ablating facing away from the esophagus as opposed to toward the esophagus with endocardial ablation. These ablation lines are actually visualized thoracoscopically that perhaps epicardial and endocardial ablation could reduce AF perpetuation. And the staged approach I like because we get to take a step back, let what the surgeon creates heal, and then a month or two later, see what the substrate looks like and see what additional ablation needs to be performed. And again, we can probably exclude physically the left atrial appendage and isolate it electrically. So I'm going to quickly go through a little bit of data that's been published about the Convergent procedure. Most of this data is single center, non-randomized. A good example of that would be this study, which was 73 consecutive patients of 4 European centers. And this was predominantly a long-standing persistent population. And essentially, what I took from this is that they had a high rate of sinus rhythm at a year, but 8 out of 73 had major complications. And that's a theme that sort of is recurrent with this data. So a meta-analysis looking at outcomes, actually comparing Cox-Maze to, which is orange, to convergent ablation in blue and catheter ablation in purple, indicates that the efficacy is much higher for convergent and Cox-Maze as compared to catheter ablation, whereas the convergent procedure in this meta-analysis had a much higher rate of complications of 10% versus only 3% with catheter ablation, and somewhat incredibly only 1% for Cox-Maze. And again, another meta-analysis essentially telling us the same thing. And the take-home message was that hybrid ablation is more efficacious, but it tends to be more complications. So the Converge trial is a very important study to talk about because it's actually a randomized controlled trial. So this study was published 2 years ago, or a year and a half ago. They took 153 patients with persistent and long-standing persistent atrial fibrillation. And this is important. The average number of years in persistent atrial fibrillation was 4 in this study. So this was definitely predominantly a long-standing, persistent, very difficult, patient population. And they actually randomized in a 2-to-1 fashion, convergent ablation to catheter ablation. Now, I think it's also important to note that we weren't comparing convergent ablation to catheter ablation, including posterior wall isolation. This is basically convergent ablation, which is posterior wall ablation, and then also pulmonary vein isolation to just pulmonary vein isolation, plus some additional lines in CAFE. But we know the additional lines in CAFE from STAR AF2 actually don't add anything, but this study was designed before that. So one could argue this is not an apples to apples comparison. Nevertheless, the study did show that the convergent patients were more likely to maintain sinus rhythm as compared to just endocardial catheter ablation. I want to make a few more comments about this. The population was predominantly longstanding persistent, but they excluded patients with massive left atrial enlargement. So anyone with patients with a left atrium greater than 6 centimeters were excluded. So we're not talking about that enormous left atrium population. Those were excluded from this study. So this is also important. I want to focus on the safety outcome. So there were no deaths or cardiac perforations or atrioesophageal fistulas. However, there were 8% of the patients undergoing convergent had complications. The complications included stroke, bleeding, pericardial effusion, and there were 3 pericardial effusions that occurred 1 to 4 weeks after convergent ablation. Now, they make a point in the discussion of this trial that the thinking is that these were not perforations. Instead, this is from inflammation from the cardiac ablation, and that these were sort of slowly accumulating pericarditis type of effusions that were managed, with drainage, and the patients did well. And they also make the point that, and this has been similar to our experience, that you really need to stay ahead of that and aggressively manage these patients for pericarditis after the epicardial ablation. Now, and very importantly, no one in the catheter ablation arm had any major adverse events. So you have to keep that in mind. So convergent ablation, similar to catheter ablation, actually does reduce AF burden. I think that's an important message because in this day and age, we're very focused on AF burden, which we should be, and it clearly did. I want to mention too the LAOS-3 study, which was mentioned in a previous talk, but this is important because I think the LAOS-3 study is showing us that patients who undergo exclusion of the left atrial appendage during cardiac surgery in whom most of the time anticoagulation is continued, have a lower risk of stroke. Now, the caveat there is that only about 15% of the patients undergoing appendage exclusion in that study received the clip. Most of them received surgical excision with overselling. So that was about 55 or 60% had the gold standard, which is surgical excision at the time of cardiac surgery. So there's a lot of caution. Most of the studies are single center, non-randomized. The definition of approaches and AF recurrence and how they measure outcomes is heterogeneous. There's clearly a learning curve. And I did find a report from MAUD that there were 9 cases of atrioesophageal fistula or esophageal injury reported with epicardial left atrial ablation over a 5-year period. So it certainly does not completely avoid injury to the esophagus, even though it's thoracoscopic. So I want to just briefly talk about our experience with Convergent, our early experience. 21 patients over the past 2 or 3 years. These have been about half persistent and half long-standing persistent AF. 3 of the 21 are still on antiarrhythmic drugs at the most recent follow-up. 9 of the 21 patients, basically the most recent 10, 9 of the most recent 10 patients underwent clipping at the time of the epicardial ablation. And about 80% of the patients are in sinus rhythm, most recent follow-up, mean follow-up being about 22 months. We have had complications with this early experience. One patient had VTVF arrest upon entry to the pericardium right before the left atrial clip was applied, and that required resuscitation with multiple shocks. The patient ended up doing well, but had a prolonged hospital course. We had a patient who was converted to open sternotomy with LV perforation, a pulmonary embolism, and a subxiphoid hernia that was repaired about 6 months after the procedure. So I want to conclude that I think there is a role for surgical approaches to atrial fibrillation, even in this catheter ablation era, even with our ability to treat patients so easily by performing PVI safely. So it allows for a staged approach to ablation. We're ligating and probably electrically isolating the left atrial appendage, which may improve outcomes. Laos 3 suggests it might, and it may improve arrhythmic outcomes also, but the jury's still out on that. We don't have to implant an endocardial device. We might reduce the risk of atrioesophageal fistula. And we do have a randomized controlled study telling us that we have improved arrhythmic outcomes with convergent ablation in this very difficult, patient population. So I think the convergent approach definitely holds promise. And certainly in general, the collaborative approach to persistent atrial fibrillation is very valuable. Thank you.
Terrific. Thanks, Sandy, very much. There are a number of excellent questions have come in. I'm going to direct one to you, then one to Dr. Jane, one I'm going to take myself, and then Dr. Cancharlo is on deck with 2 questions. So, Andy, with that, is there any benefit for patients with longstanding persistent in putting them in amiodarone, converting to see if they'll maintain sinus rhythm as opposed to going to surgery?
Yeah, Mark, that's a great question. We do take that approach sometimes. Actually, I want to take a minute. I want to acknowledge Erica Byers, because Erica is one of our nurse practitioners in our EP practice, and she's been integral in really helping with this program and also the database. So thank you, Erica. Appreciate it. But I was just thinking of seeing patients with Erica in the office, and we do talk about doing that. I think that's a reasonable approach. If you're not sure if this is completely futile, is there any chance? Also, sometimes useful to gauge a patient's symptomatology. Try to maintain sinus rhythm for a period of time on amio, and ask them, do you feel better or not? And then decide whether to proceed with something that's pretty invasive.
Sandy, a question that comes up frequently, which you touched on, is it always a mainstay of therapy for the paroxysmal AFib to try a drug and lifestyle, or is it okay just to go right to ablation as first line? And how would you select those patients to go right to first line?
Yeah, I think this is definitely evolving. If you asked me a couple of years ago, I would say absolutely drug first is what I recommend to the patient, and discuss the lifestyle piece as well. I think with the two trials that we showed, it's a lower bar now, and I think a lot of that is driven by the patient. And I have definitely gone first line to ablation in that young patient with a normal.
Yeah, it's again a shared decision making, and this is
Yep.
one of the things that I think their referral to the AFib center can do is to get the risk and the benefits of various approaches, make sure that there's lifestyle modification, and even indeed patients who've been in persistent AFib, getting them plugged in to best available therapy, which may involve surgery as well. A quick question about dronedarone. Is there any role for it? Very limited. The Athena trial showed that it reduced hospitalizations, and when people had AFib, they were less symptomatic. But the Palace trial showed when it's used in patients with heart failure, there's an increase in mortality and MIs. Very, very limited role for dronedarone. In fact, most of the patients referred to me that have been on it long term, I find a way to get them off of it. Krishna, 2 quick questions and perhaps 2 quick answers in the remaining 3 minutes.
Thank you, Mark. And first, thank you for those excellent presentations, review, and recommendations, Dr. Jain and Dr. Voigt. First question for Dr. Jain. As an electrophysiologist, I see often patients with risk factors in clinic with atrial fibrillation. The atrial fibrillation itself is a constricting, activity limiting, and somewhat fear-provoking problem for these patients. And we do recommend lifestyle modifications, but I hear often back saying, I can't do them right now, I'm stuck. So how do we actually handle this issue of, okay, now I need to have you start the CPAP therapy, lose weight, start this process before we decide whether we need some rhythm control approach or ablation versus, scenarios like, okay, let's go to the rhythm control ablation. So you are feeling better, so you can continue to get these lifestyle approaches affect your outcomes in the future. So how do you balance this situation?
Yeah, I could count on you, Krishna, to ask a very difficult question. The challenge, I think, is, and this is where oftentimes even an antiarrhythmic, as Andy mentioned, amiodarone to sort out how much of this is their AF, how much is everything else going on. And I think I would highlight back to what we said before, the earlier we see them, the more chance we have impact with any of these things, and the more time we may have in their symptom complex to say, go try some of these things, as opposed to seeing them 2 years into the diagnosis when they're often fed up at that point, and you're kind of ready, they're ready for the next step, and you have a lot less involvement. But I think we should be pushing those things. I don't think we always have that answer or luxury of time, but I think it has to be in a coordinated way on that first visit early in the diagnosis.
Thank you. And I think that early, maybe this screening AFib that Dr. Bosley presented gives us the opportunity to affect their lifestyle. I appreciate the earliness in your comments. Dr. Voigt, last question, I'll keep it quick. So every intervention has a learning curve, and we do have more complications early, and they get better over time. But this is a very impressive outcome in terms of AFib burden reduction and AFib outcomes for a long-standing persistent patient. So what do we see the future offering us in terms of reducing these complications? Is there a way that we can actually reduce the complications of hybrid ablations going forward?
I think so, Krishna. Yeah, I just wanted to clarify, only about half of our patients have been longstanding persistent, but yeah, I think there is. And I think in speaking to my surgical colleagues, they feel very comfortable that with time, these kinds of procedures become safer. And we've actually already seen that in our experience. And I think actually, especially with the left atrial appendage clip, since LAOS 3, that's become very common. Our surgeons are doing the clip a lot. So adding that on to a procedure like this, I think is becoming safer. So that part of it for sure. I think they've also improved the subxiphoid approach. At one time, it was transdiaphragmatic. Now they're not doing that, and it's actually leading to fewer complications. So we're seeing improvements already.
Okay, with that, let me thank the two speakers for superb presentations and also the attendees for some excellent questions, and particularly the online attendees who are flooding in with some terrific questions, which our next moderator, Dr. Jain, is going to have the challenge of addressing as the cases are presented. So thanks again. We're going to turn things over now to what is going to be a proactive case discussion in which we want to engage the audience. Dr. Jain.
Thanks. So maybe if we can have all the presenters and the panelists come up for this next section, so there'll be a nice full round here.